Despite a century of controversy, EPT is fundamentally flawed biologically, technically, and clinically. Its use persists because of tradition, compliance, not logic or science. Hello, and welcome. I am Marwan Aburas. I suggest there are 5 reasons why you should not use the electric pulp test in your practice or recommend it. They are essentially the objectives of this presentation. Biologically, a tooth can have a pulp that has lost its cellular, its vascular components, including the A delta fibers, but still have the C fibers, which survive, resist, and respond to electric pulp test. The literature recognized this as a false positive. This biological fact alone should prompt us to question the use of EPT in dental patient care. The dental pulp is a complex and sophisticated organ. In a molar, one canal's pulp can be inflamed, another necrotic, and a third is healthy. But the pulp chamber is calcified, and the question arises, which canal is responding to the EPT, CPT, or HPT? This is why Seltzer, in 1960s, advised us that the electric pulp tester is reliable only in single-rooted teeth and when they are completely necrotic. This diagnostic limitation alone should prompt us to reconsider the use of EPT in dental patient care. Technically, for over a century, EPT users debated whether to use bipolar or monopolar methods. When they finally agreed on monopolar, they still differed on electrode placement: incisal edge, occlusal third, mid-buccal, cervical, mesial, distal. In 2007, Lynn from the University of Ottawa, New Zealand, explained that the best placement for the electrode on maxillary and mandibular molars is at the mesiobuccal cusp tip, where there is the highest concentration of nerve is located. He warned us that placing the electrode cervically might cause false negative, and we don't want that. My friends, this lack of universal agreement on where to place the electrode is a crucial issue and should prompt us to question the use of EPT in patient care. Then there is the problem of false positive caused by electric current spill over to the periodontal ligament, to the gingiva, to the adjacent teeth. Some clinicians dry the area with air or isolate with cotton rolls, while others use rubber dams. For current conductive, some use toothpaste, others use topical anesthetics, yet another group fluoride gel. Some say that anesthetic gel might interfere with the response. Jaffer Sada in 2010, an excellent article, described how rubber gloves used in patient care, in equipment safety, how they could contaminate the electrode. He discussed the controversies and the multiple methods proposed to solve that problem. Just wearing gloves. And closing the circuit was not only cumbersome, but hilarious. Field isolation and current conduction, this lack of technique standardization in healthcare, and lack of evidence based on guidelines alone should make us question using EPT in patient care. Clinically, we agree that when patients come to us, they typically complain of pain, sensitivity to hot and cold. We agree. Or difficulty in chewing, or biting, or tooth mobility. To diagnose and identify the problem, our examination should reproduce these symptoms and demonstrate their duplications. After 50 years in practice, I cannot recall ever a patient complained of pain and sensitivity to electricity in their teeth. This clinical irrelevance to patient complaints should lead us to question the use of EPT in dental patient care. Pitford and Patel in 2004 outlined beautifully the ideal features of a pulp vitality tester as being, first, able to assess blood flow, provide objective measurement, free from error, effective for heavily restored teeth, effective when the pulp size is reduced, quick and easy, and inexpensive. But when we apply these standards, it is clear that none of the current pulp testing methods fully meet these criteria. It's very concerning to me that EPT is still taught in dental schools and appears in textbooks as a valid pulp test. This confuses dental students and practitioners, perpetuates outdated practices. The EPT creates a false sense of diagnostic certainty, which we could be misleading, potentially dangerous. My friends, as endodontic clinicians, endodontic educators, dental educators, we must pay more attention to the broader context of endodontic diagnostics, which include the patient narratives, insight in these beautiful radiographs, and the story of the pulp within the overall condition of the tooth and the story of the tooth. And this is exactly my proposal to the tradition. That's what I proposed in the 1980s, the stress pulp concept, which I use in my practice and teaching, and I refer to it the STP test, the stress pulp test. It's very true. Thank you for listening.